So now we are on live. We are good to go.
Good evening, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. Today we have got honorable speaker Dr. Sheela Mane with us. Welcome, madam. This program is brought to you by Hetero Healthcare. Hetero Healthcare has 25 years of excellence, 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Hetero Healthcare is the largest closely held pharmaceutical company in India. It's among the largest manufacturers of ARV, APIs and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, Experience Sharing Program in Managing PPS, as I said, we have got Honorable Speaker Dr. Sheela Mane. Dr. Sheela Mane is MBBS, MD, FICOG and FIC-MCH, ICOG Chair-elect, Vice President Foxy 2014, Chairperson Safe Motherhood Committee 2008 to 2013, President BSOG 2005 to 2006, President BMS Bengaluru 2019 to 2021, National Facilitator Adolescent Health WHO, ICOG Governing Council Member 2020 to 2022, Ex-President Bangalore Menopause Society, President ISO PARB Bangalore Chapter, Reviewer for JOGI, Faculty FIGO PPH Simulation Workshop. Welcome, Dr. Sheela Mane, and I'll start the presentation, madam.
Thank you. So this is about the overview of postpartum hemorrhage. I would like to thank Hetero Healthcare for inviting me to give this talk on a very important topic which is close to my heart, and that is postpartum hemorrhage. So all of us, we know that postpartum hemorrhage is one of the leading cause of maternal mortality in our country. And the definition which we used to use earlier as 500 ml blood following vaginal delivery and 1000 after cesarean is been recently changed by WHO on 5th of October 2025 at FIGO. So now the definition is if the patient becomes hemodynamically unstable, that means if there is a fall in blood pressure, increase in her heart rate, then we have to consider it as postpartum hemorrhage. So it is not always the quantitative estimation of blood loss, because the anemic patient even can go into shock or hypotension even with 300 or 350. So blood loss estimation, it becomes a very important tool when we are conducting deliveries, because that will lead us to early diagnosis of postpartum hemorrhage. Next slide, please. Next slide, please. Hello. Yeah. Yeah, next. So it is common, and these are the 4 causes like tone, thrombin, trauma, and tissue. So the commonest is the atonicity of the uterus, which is the most common. Then comes the trauma, then the tissue, and thrombin, that is coagulation failure, is very rare. That will come at 0.5. But atony, which is the most common its cause, is responsible for 70% of postpartum hemorrhage. Next. So the clinical findings will again differ depending on the blood loss. We have a degrees of shock, and in that we have mild, moderate, or severe, and earlier it is compensation. So what happens is in compensatory phase, there are not much changes in the pulse and blood pressure. And there we find that certain parameters, clinical parameters, which I'll be discussing in the panel, like shock index, will come to our help, where we find that always the pulse rate has to be lesser than the systolic blood pressure. Once the pulse rate becomes more and the systolic blood pressure falls, the shock index will increase. And in that case, we know that this patient is becoming hypovolemic. So if earlier stage between 500 to 1000 ml, if the patient is not anemic, she may withstand. We may not find much difference in the clinical parameters, but she may complain of dizziness, tachycardia, palpitation. But if it crosses 1000 ml, then there will be fall. There will be, patient will have sweating, tachycardia, which are all the signs of hypotension. Still more, 1500 to 2000 ml, which we call it as a class 3 hemorrhage. there is a marked fall, patient will have a restlessness, she will be struggling to breathe, her respiratory rate will go up, even the urinary output will come down as there is a hypovolemia. And in a severe condition, severe hemorrhage or a massive hemorrhage where the blood loss is more than 2000 to 3000 ml, that is, it has crossed the half of the blood volume of that patient will be in a state of shock or she may collapse also. Okay. So there could be circulatory collapse, increasing abdominal girth, that could be because of the collection of the clots in the uterus. You will find uterus is not contracting, tachycardia and vaginal bleeding. Next. So the approach towards postpartum hemorrhage is like we have to see poor uterine tone. So we'll have to immediately palpate the patient and see the abdomen, whether the uterus, where it is filled. Because if it is filled with blood and all, it will be above the umbilicus, because normally after the patient has delivered and if the uterus is tonically contracted, it is at the level of umbilicus. Then we have to start sending the investigation depending on. Suppose if it is a severe blood loss, it is not only the full blood count, but we will get even the coagulation profile done, because the patient bleeds more, she will go into DIC. Then you also get her renal function test done and the electrolytes. Yes, if facilities are available, you would like to do the ultrasound to see whether there is any tissue left. And management comes is the oxytocic medical management is the first one. So estimation of blood loss, you know how much is the blood loss, you know the class of hemorrhage, and then you start your drill. So you will have to keep the patient hemodynamically stable. So the first thing what you do is you start IV fluids with a big bore cannula. I will come to that in the panel, because if you feel she has bled, till you get the blood and blood products, it will take time. And continuously, simultaneously, you are also giving oxytocins, prostaglandins, ergot alkaloids, as well as you have to give her oxygen. You have to see to it that you do all the measures to arrest bleeding. Then if there is a trauma could be uterine rupture following cesarean or a prolonged labor. During cesarean, there could be extension of angles, okay? And there could be extragenital causes also. That is very rare, like subcapsular river. That happens in cases of HELP syndrome, which is associated with hypertensive disorders of pregnancy. Now, during cesarean section, we have to identify everything. If it is a vaginal delivery, we will have to again explore the cervix, the vagina, whether there are any tears, particularly after the instrumental delivery, there could be cervical tear, which can extend even to the fornix. And that case, it becomes like a rupture uterus, where you may have to open up the patient because patient bleeds. Retained tissue could be the retained placenta and membrane. Suppose if it is adherent, then we will have to examine the patient under anesthesia, and we may have to do manual removal of the placenta. Coming to the coagulopathy, again, you will have to send for the coagulation profile, that is PT, APTT and INR, and patient will require immediate replacement of blood and blood products, that is PRBC, FFP and platelets. So we have to make the attempt to identify the cause. It is very important to see, next slide please, which T is causing this bleeding. Now, we know all of us now that in 2018, WHO recommended Carbetocin recommendation. 1A is oxytocin and 1B is Carbetocin. And a heat-stable Carbetocin, particularly for LMIC, low middle income countries. So Carbetocin is available now as a heat-stable. And the other oxytocin or ergot or even carboprost, we have to keep them in the refrigerator, which is very important. And earlier Carbetocin preparation also needed refrigeration, but now we are proud to say that the champion trial, which was done by Cayley Institute in India for the heat stable Carbetocin. So it is a heat stable, shelf life 24 months at 30 degree and at 75% humidity, and it avoids the need for cold chain. So sometimes if the cold chain is not maintained for oxytocin, it loses its potency. Okay. And it is provided as a vial. Next slide, please. So now when do we give? Okay, if I have to talk about active management of third stage of labor, the recent recommendation by the government of India is the oxytocin drug, either oxytocin or Carbetocin, oxytocin 10 units, either intramuscular. If there is IV line, some people say that you can give IV slow. Even WHO recent recommendation says that if there is a IV cannula, IV line is there, we can give IV. Or now in India, we don't talk about IV because periphery, we don't want them to give that because IV oxytocin can cause complications. So 10 units of oxytocin intravascular within 1 minute after the delivery of the placenta, and you have confirmed that there is no second baby inside. Carbetocin also same thing, that is which is available as a 100 microgram, which has to be given intramuscularly. Now ergometrin is no more used, symptometrin we don't have, and misoprostol is not a primary drug for the prevention of postpartum hemorrhage, except in cases of periphery where the patient has delivered in a periphery, there are no facilities available. In that case, the ANMs or the ASHA workers are given the misoprostol. About 600 microgram of misoprostol is given orally to that patient. So active management of third stage of labor can prevent 70% of postpartum hemorrhage. Next. So this is the carbetocin, and it is a synthetic long-acting analog of oxytocin, and it is used right now. Currently, the recommendation in India is only for prevention. Okay, and 100 microgram in 1 ml solution is available, and it was created by making several modifications to the oxytocin structure. So it is nothing but analog of oxytocin, but there is a prolonged half-life and it reduces enzymatic degradation. Next. So if we have to compare carbetocin and oxytocin, synthetic cyclic peptide from one of the naturally occurring posterior pituitary is oxytocin, and it binds to oxytocin receptor, and that's how it stimulates the contraction of the uterine smooth muscle. Okay, and intravenous almost immediate action within 30, and the peak concentration is after 30 minutes. Intramuscular within 3 to 7 minutes, half-life is 1 to 6 minutes. We are talking about oxytocin. You have to refrigerate it, and cold chain need to be followed. But you can use it for induction of labor, augmentation, AMTSL prevention, as well as treatment of PA. But carbetocin currently is only for AMTSL. It is long-acting synthetic analog with oxytocin with agonist properties. It binds to receptors only, resulting in rhythmic contractions. So there is an increased frequency of existing contraction and increased uterine tone. IV, sustained uterine contractions within 2 minutes will come and lasting for about 6 minutes and followed by rhythmic contractions for 60 minutes. If it is given IM, the sustained contraction lasting for about 11 minutes and then rhythmic for 120. So if it is given IM, it lasts for more 2 hours. Half-life is 40 minutes. Storage up to 30 degree as it is heat stable, but no, it is not used for induction, not for augmentation, not for treatment, only for prevention. Next. Now, the clinical evidence is champion trial, as I told you, which was conducted in 10 centers in India and in 10 countries by the WHO. And they have shown that the carbetocin is non-inferior. It was 30,000 women where it was used, but it was used in vaginal delivery and it is non-inferior to oxytocin was the conclusion of this trial. Next. Now they have compared the blood loss, carbetocin, and yes, blood loss, that there was not much difference. Even for the more than 1000 ml also not much difference. And at least one anticipated adverse effect was found almost equally, and one serious also was found. So the frequencies of expected AEs did not differ significantly. The frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior and same. So it is non-inferior, that is the conclusion of the study. Next. So this is the Cochrane review, which talks about those studies. Next. That says that who undergo cesarean section, please go back. Carbetocin resulted in statistically significant reduction in need for therapeutic uterotonics and is associated with less blood loss compared to symptometrin in prevention of PPH. And we have also experienced it when we have used it. And in cesarean particularly, because it is given IV, the blood loss is very, very less. Okay. And next slide, please. So it's very important for our country, because our women, most of the women are anemic. About 45% of anemic pregnant patients are anemic. So what are the guideline recommendations? Guideline recommendations, WHO, I told you, first is oxytocin, then comes carbetocin. Okay. So the SOGC, that is Canada, yes, is the first one. FIGO is one of the recommendation for the PPH management. Okay. And Germany also uses it. and France also is using and proving non-inferiority. So these are the countries who are using it worldwide. Carbetocin is being used. Next. So experience, if I have to say, definitely we are looking for zero deaths in preventable PPH. Yes, PPH will be there, but we have to manage it in such a way that there are zero deaths. We have to assess shock index for early clinical diagnosis. E motive. What is E motive is estimation of blood loss. M is for massage. O is for oxytocin. T is for tranexamic acid. Don't wait. You're giving oxytocin, give tranexamic acid. IV is for IV fluids. You'll have to maintain the patient blood pressure. And you have given the oxytocin, you have given oxytocin, ergometrin, prostaglandin. I'm talking about management of PPH. Still not controlled, then you escalate. And there has to be readiness for every facility and risk assessment has to be done antenatally, intranatally, as well as post-delivery. So it is not that. Antenatally, you have to assess who is at risk. During delivery, prolonged labor, PROM, precipitate labor, okay, multigravida, cesarean section, these are all the risk factors. Antenatally, anemia, PIH patients, preeclampsia patients, short-statured patients, all these are. Why? Because in a small-made woman, the blood volume is less. She cannot withstand. Even if her total blood volume may be only 3.5, she is small-made. She loses 1,000. It is 1/3 of her. So she will become hemodynamically unstable. And you always need a multidisciplinary team for complicated cases. Next. Next.
These are some of the questions, madam.
Yeah.
Why is the incidence of PPH more in India? Is
It
it
is
because of
all.
anemia or?
It is around 30%. I must tell you, it is coming down now.
Okay.
And hypertension is taking the first seat now.
Oh, yeah.
The maternal mortality, but that is mortality. But
Mortality.
PPH was the leading cause, and it is a leading cause for maternal mortality of 30%. The
Okay.
incidence of PPH is about 6 to 8% in cesarean and 4 to 6% in vaginal delivery.
But is this more than other countries or it's almost the same?
No, more than it is almost the same. No, we are
Almost the same.
comparatively lesser if we
Okay.
compare the like South Africa
Okay.
and other countries.
It's
Definitely,
lesser.
I mean, in CFOC countries, Southeast Asian, yeah.
Okay. And is anemia considered a serious? Of course, you did address this in your.
Yeah, why anemia is considered, because the anemic patient has tachycardia. So
Correct.
her cardiac output is more.
Mhm.
So the heart is pumping more. Now she
So,
has
yeah,
atonic PPH,
correct.
she will bleed more.
Correct.
Second is, as the red blood cells are lesser, the count is less, so the lamellar flow in the blood vessel is lost. So
Okay.
there are no platelets at the periphery to plug the open ends. So she bleeds more. Third, there is an increased viscosity because of
Yes.
the dilution. So she bleeds more. Okay. Then fourth, it is iron deficiency.
Correct.
That makes the myometrium weaker. Okay.
The
So
strength of contraction.
yeah,
Yes.
because there is no iron. So the
Yes.
muscle, even the uterine muscle is not strong.
Correct.
So
Correct.
collectively put this, anemic patient is at more risk.
And anemia is a problem in our country, especially in the rural settings.
Yeah.
We have seen some of the patients as low as 5 or 6 also hemoglobin.
Yeah, we have seen 3, 4.
Yeah, yeah, correct. 5 or 6 sometimes is a luxury. Three, only say three. In which cases, do you generally prefer IV route or IM route?
We prefer IV route in cesarean.
Okay.
IM in labor room because nurses will be giving.
Okay. Okay.
Okay. Because sometimes, if it is not given slowly, it can cause hypotension. Few
Yes.
cases it did. So we don't want any side effects. Okay.
Correct. Correct. Correct.
IM route, we know that it takes 11 minutes. IV route, I think it takes lesser time.
Instantaneous, almost instant. The duration of effect may be slightly longer with IM route.
120 minutes. Yeah.
But any experience of using carbetocin in RH negative mothers?
Yeah. See, any high-risk patient today,
Yeah.
it is carbetocin.
Correct.
Earlier, they used to say that we cannot use in severe preeclampsia, but now no, we have used it. Because hypertension patient also has a vasoconstriction of the vascular compartment. She's also like anemic patient. Even if she loses less blood, she will also have
PPH.
hemodynamic instability. RH negative, we know it is not easy to get RH negative blood. All
Exactly.
these mothers, high-risk patients, polyhydramnias, large baby, prolonged labor, carbetocin is the choice.
In your practice, carbetocin is the first drug that you use as oxytocin. And generally, I mean, this is a question for generally doctors use oxytocin for induction. In such scenario, can a doctor use carbetocin for prevention of PPH? He is already
Very good
using.
question. See, the carbetocin, the oxytocin, which is used for induction of labor, the dose is very less. It is milliunits.
Okay.
Per minute, how much we are giving is milliunits.
Okay.
5 milliunits. Even
Yes,
though
yes,
we
yes.
have added 5 units to the bottle, the dose is adjusted in milliunits, which is
Correct.
very minimal. Okay. And the half-life of oxytocin is very short.
Okay. So the effect
So,
wears off.
so effect wears off. So we can use.
Is it any difference? Suppose oxytocin someone gives by bolus or someone gives by drip. Is there any difference in this effect of carbetocin afterwards?
No, even if you see for induction, we are not going to run it fast, no?
Okay. A slow drip.
Yeah, it's a slow drip, no? Because oxytocin has its own side effects when we are
Correct.
giving it to the
But
pregnant uterus.
coming to oxytocin, but have you ever anytime seen the ADH related side effects with oxytocin in your practice?
No, I mean,
No.
see, sometimes post-operatively, suppose we have, I don't think in induction of labor, how much oxytocin?
Yeah,
See, if
correct.
we have given it for the treatment of PPH continuously,
Ah,
like 20 units we have added, still not control, another bottle we have added 20 units like that. If we have given that much, already she has PIH or hypertension, her kidney is compromised,
then
then
it
it.
is a problem. Correct.
But now the limit is 80 units in 24 hours.
Okay.
Hmm.
What is the advantage of using carbetocin over other uterotonics for prevention of PPH, both in cities, metros, and periphery? I mean, heat stability is, of course, one of the major.
Yeah. Why differentiate? Periphery all the more required because the
Yes,
patient will bleed less.
absolute.
Chances of referral will be lesser. Uterus will remain contracted even though she
Correct,
is bleeding at least for longer time it will
correct,
contract.
correct, correct, correct.
Okay. And side effects are not there except one contraindication is epilepsy.
Acha,
Epilepsy is the contraindication
okay.
that we have to remember. And in cities, so now I think everybody is using
Using
carbetocin.
carbetocin.
Okay. Right.
And how it's tolerated generally.
Yeah, I mean, I think that's what I told you, no? Very few patients developed
Side effect.
hypertension. Yeah.
The first line is, of course, I mean, you have already answered this.
No, see, the
And
thing is now in public sector, it is still not available.
yeah, correct.
Government of India has still not put it in emergency category.
Essential drug
So
list.
it will come slowly. We are
Yeah.
in dialogue with them. Essential list, it is still not there. And we are trying to publish studies and trying to tell them, trying to impress upon them. It will come.
Correct.
Okay. Because the benefits are like blood loss is less.
Yeah, yeah, yeah.
Okay, and the action remains for a longer time. And why it is important? Because the fourth stage, which is the 1 hour observation of the patient after the delivery, is most of the time not done.
Correct.
People are not there vigilant, watching. And that time the patient bleeds, and after that
Collapse.
they see she is in a state of shock.
And
The carbetocin action will last longer.
and in many public hospitals, there are five, six ladies going to labor simultaneously. I mean, at
HR
that time,
problem, no? Human
yes,
resource problem is there.
yes, yes,
Many
yes.
deliveries. Yeah.
Madam, put your overall experience and take-home message for the audience.
I have done a study, a comparison.
Oh,
Okay.
comparison with
Oxytocin.
oxytocin. Okay,
So the blood loss was not that much difference in
different.
vaginal delivery, but cesarean drastically it reduced.
Okay,
Additional oxytocin not required.
okay.
Okay. And additional oxytocin not required is another point, and the comparatively lesser blood sup. And
That's right.
naturally, the fall in hemoglobin was not that much.
Obviously,
So
yes.
postnatally, the patient was in a better condition.
Lovely, madam. Madam, thank you so much, madam, for sharing your experience. I mean, it's a pleasure, listening to PPH. PPH is one condition which is excellent to discuss, but one should never get that. And in my era, when I was in JJ Hospital, we had only oxytocin and methergine. And we had a patient apparently going well into the delivery and sudden a drop in PPH, and you know what it is then.
See, ergometrin is a good drug, but now,
Yes.
I'm not, because it contracts both upper and lower segment.
Correct,
Now
correct,
also we
correct.
use it if there is a bleeding from the lower segment,
Correct.
because oxytocin analog and oxytocin acts only on the upper segment.
Upper segment, yeah.
But lower segment, ergometrin acts.
Ergometrin act.
So for the management of PPH, yes.
Yeah.
Earlier we used to use even for prevention,
Prophylaxis, yes, correct.
ergometrin. But the people in the periphery may not be able to rule out heart
Yeah,
disease or high
cardiac,
blood pressure.
correct, correct,
So
correct.
that's me. And again the storage.
Yes. Thanks so much, madam. I don't want to take your time. Thank you so much. I'm sure the audience has benefited. Thanks for taking time and addressing this webinar. Thanks all the doctors for attending this webinar in the evening. Thank you, marketing and sales team of Hetero and IT team for your support. Thank you. Madam, you can sign off. Wish you a very pleasant evening. Thank you.
I think you can stop share. I will share my PPT.
Yes, yes.
I think can I share mine?
Yes, madam. Please.
Can you see my slides?
Yes, madam.
Yes, ma'am.
Yeah, fine.
Yes, ma'am.
Yeah, so I will just go through quickly most of the things we have discussed.
Really?
And that, can you remove that top? I think my heading is getting blocked. Or you just take it up, that black thing.
1 minute, ma'am.
So, sometimes you get this type of picture in labor room, which is so scary. And obstetric hemorrhage is different from other hemorrhages as the patient can go in for DIC early. So all we discussed about the 4 T's. Now there is a patient who delivered and nurse noticed a sudden gush of blood flowing. AMT, I mean uterotonics were given, massage started, bimanual compression done. Still the uterus was found to be flabby and there was no IV line as the patient had come and active deliver and delivered. Now, how do you quantify blood loss? That is the most important thing because you have to assess the blood loss. Now, those who are in public sector are using a Kelly's pad. What do you mean by Kelly's pad is that will help you to drain the blood into the bucket. So you can keep a measurable jug there. Or you can weigh the blood soak pads, linen and gown. Now, unless and until you get into this habit, it is very difficult to do. Okay. So you have a swab, you will have to see how much is the weight of the dry swab, how much is the weight if it is completely soaked, the same way with gown, with Euromat and with sheets. So you should have these type of labels put up in the labor room. And then you will have to calculate. So direct measurement is from collected blood in the drape, which is there below the patient, which is very important. And the other things which you have weighed, and that is the total blood loss. And accordingly, this is the quantitative method. So that will be the total blood loss. Now she had noted that the collection in the drape was 100 ml before delivery. That could be amniotic fluid, so you minus that. After delivery, the total drape collection was 700. So, and the dry weight of 5 mops was 100 grams and 10 mops were used. So if you calculate, the final weight of the mop was 575 grams. So like that, you collect the dry weight, then the weight of the blood lost in mops. So wet weight minus dry weight is 375. In drape, it is 700 minus 100. That is amniotic fluid. So total loss is 975 ml. So this patient is going in for class 2 hemorrhage. Now IV line, you have to immediately start the IV line with big bore 16 gauge cannula. 16 gauge is gray color. Never start pink or blue. Okay, because if you are using 16 gauge cannula, you are transfusing almost 180 ml of fluid per minute and your patient bleeds like that. And add 20 units to the drip. The patient expelled a large clot. Her pulse was 120, BP was 80. So you divide this 120 by 80. The shock index is going to 1.5. And this shock index normally is 0.7 to 0.9 in a pregnant patient or a delivered patient. If it goes beyond 9, that means your patient is bleeding and she has hypovolemia. Then the another oxytocin carboprost was given. So what is shock index and how it is useful? I told you how to calculate it. It is an indicator of hemodynamic instability and hypovolemia. The sensitivity is good. Okay. So you have to calculate that. So this is the classification of hemorrhage, I think, which we learnt already. So what do? It is not only call for help. If your patient is bleeding, you shout for help. You have to assess the airway, breathing, cardia, everything. So ABCD assessment you have to do. Two wide bore cannulas, collect the blood for investigations, CBC, cross matching as well as coagulation profile. Put the catheter, palpate the uterus, rule out trauma, uterotonics, emotive, I already told you. Depending on the condition of the patient, if you are able to manage in the labor room, you have done bimanual compression, you have done aortic compression, she is responding, you will wait and watch. You will look at the shock index, starts improving, you know patient is doing good. Otherwise, you shift her higher to a higher center where there is ICU, HDU, all you call for more experts. Okay, if you are not able to, let more and more people come and talk to the patient and communicate. So this was a simple kit which we prepared in Bangalore Society where everything is kept. Now we have divided. So you can have 3 boxes, A, B, C. A is related to air where you keep a mask and a, um, the mouth gag, because you have to give oxygen. Sometimes in case of hypotension, there can be, the tongue can fall. Then you have a blood B related to blood. So keep your cannulas, IV set, blood transfusion set, then your tape, even a scissor to cut, as well as the blood to bottles to collect the blood, like red color, blue color, as well as purple color. All those things you have to keep there. And C is for catheters, whatever is required. So like that, be prepared for every patient. Tranexamic, I told you, emotive trial, there is no more waiting. You have to give tranexamic, and it has a enhanced fibrinolytic activity, and fibrinogen depletion are common in early stages of bleeding. So what does tranexamic does? If bleeding, if you give this, it will help to form a clot. Okay. And if the clot is formed, naturally the bleeding will be reduced. Immediately it will act. You can repeat it after 30 minutes, or if you have already given, then you can repeat it after 7 to 8 hours. 1 gram to be given. And it reduces death due to bleeding by 19%. Okay. And it was found that it was reduced by 31% when treatment was initiated within 3 hours. So you should not delay giving. It has to be given early. So according to Japago, given it within 3 hours, it will reduce the mortality by 30%. Okay. That is important. And WHO also strongly recommends, and just now I told you about emotive. Forget about the earlier one. Prophylactic, as such, WHO does not talk much about prophylaxis, but in cases of cesarean, it has a role of prophylaxis where it can be given before you extract the baby. They found that it can reduce the blood loss. Anti-shock garment must be there. It is a non-pneumatic anti-shock garment which should be applied as soon as the patient starts bleeding. It controls bleeding through direct pressure because it is applied to the lower body. It has 6 segments. Auto transfusion of a blood in an upward direction. There is a ball in the abdominal segment. Applies focus pressure on the uterus. There is a circumferential pressure on lower half of the body, reduces the total vascular space. Vital organs gets increased blood supply and oxygenation, and stabilizes the patient during transport. So this is the anti-shock garment, and I must tell you, every facility must have this. Okay, it is the need of the hour, and WHO says you must have it. Okay, it can be kept even 16 to 36 hours. Okay, ideally till 8 hours. Once the patient is stabilized, then we can remove it. Okay, but you will have to make all other arrangements and control the bleeding. What is uterine tamponade? Another method, immediately, if your medication has failed, you escalate and use tamponade. Tamponade is different types of balloons. These balloons can be inserted into the uterine cavity, which will occupy the uterine cavity, and it can stop the bleeding. It has to be inserted properly. If it is low, it will not, the cavity of the uterus will be left empty, and then it will not control the bleeding. There are different, you don't have anything, you use a glove. You can use a condom. Okay. And there are now so many different types of uterine balloons which are available. You have Bakri balloons, so many things are there which you can use. Okay, particularly in uterine atony, vaginal deliveries, it has given 87% success. Placenta previa, even lower segment also it can compress, 86%. Cesarean 81. And even in placenta accreta, sometimes when we have removed the placenta, not completely, partially, we can use it because it will definitely help control the bleeding. We also use it during cesarean. Now, the another method we have is a suction cannula. In South, it is very popular. We use a suction cannula that creates a negative pressure in the uterine cavity and results in cessation of bleeding. It is introduced and the negative pressure is raised up to 700 millimeters of mercury, and immediately it will contract the uterus. Okay. After 15-20 minutes, you switch off the suction and then you leave the cannula in place. You find again all other measures need to be taken: oxytocin, replacement of blood and blood products, everything. You find again the uterus is becoming again you can switch it on. And we are all using it and we are really happy about it. So there are different SR cannulas, Panikar's cannulas, and we are proud that they are all indigenous and made in India. And they are available different sizes. For vaginal delivery, you have little longer, and for cesarean, you have little shorter one. Carbetocin, I think I discussed already, so I will not go into that. We know about carbetocin, so I'm not going to talk about it. I will just, so newer drugs also we discussed about it. Any novel methods now? I told you about the condom tamponade, it can go up to even 750 ml. And pack. If we have done the hysterectomy and if we find that there is a lot of bleeding inside, we can just put a cap inside the abdominal cavity, pack, okay? And then you bring it down from the vaginal vault and then keep it there, apply weight to that so that it will help to compress the bleeding. See, nowadays we have different methods. We do two-step method. We don't do this. We pack the whole abdomen, leave the pack in situ, give higher antibiotics, and then again reopen after some time. This particularly happens in cases of DIC, even following hysterectomy, as well as in cases of HELP syndrome. Newer instruments are the clamps, and these clamps can be applied vaginally. If there is a bleeding, this clamp is applied to the uterine vessel laterally. So when you apply it laterally, you pull the cervix and then you take it to the right side, you apply it on left side, ureter will fall away, don't worry. When you want to apply it on right side, hold the cervix, bring it on opposite side, and then apply. And that can be left in situ even for 1 or 2 hours. It will be clamping the uterines from below. Okay. So these are the clamps. We have Dr. Paili's clamp. Okay. And then we also have Dr. Ramlingappa's clamp, which can be applied, and you can see how the ureter falls away. So we don't have to worry about it. Now, for cervical inspection, there could be traumatic postpartum hemorrhage. Keep this type of tray ready, where you have 4 sponge-holding forceps, 3-4 Alices, your long needle holders, and a pack, because you will need adequate ribbon gauze if there is any oozing or anything. So this tray should be kept ready. You should not be searching for the instrument. Now, in traumatic PPH, tranexamic can be given. Your oxytocin will not help. Now, suppose if the patient has an adherent placenta, then what do? If it is a case of a placenta previa or a placenta accreta, you have to take an informed consent. There has to be a multidisciplinary team, IV access, blood and blood products. Means you have to have a MOU with the blood bank if you are in private. Or you have already informed the blood bank to keep all the blood products available. And you will need a Foley's catheter, ureteric stents also sometimes, and a uterine incision you have to decide before where to put. So you may do ultrasound and then decide where to put the incision. All the drugs, anesthesia, post-op care, and sometimes you may require radiologist help, interventional radiologist to do uterine artery embolization as well as the thromboembolism prophylaxis. Coming to the surgical method, now we have done the vaginal delivery. If we have done not control, you will have to shift her to OT. And then you will have to, if you want, she's a primary, you have to preserve the uterus. So you do uterine compression like B-Lynch or Heyman's, or you do O'Leary stepwise devascularization. First you do the uterine, then you do the utero-ovarian anastomosis. Still not controlled, you can go for internal iliac artery ligation or utero-ovarian vessel. Triple P procedure is used in cases of adherent placenta where you want to preserve the uterus, where you have to just cut the portion of the uterine wall where the placenta was attached. You need expertise. You have to do it in a tertiary care center with multidisciplinarity. While if you find that the patient is bleeding from the lower segment and sometimes you may proceed with hysterectomy, you can use a tourniquet like a Foley's catheter, tie it around the lower segment because the placenta is in the lower segment. That will help to reduce the blood loss. Sandwich technique we rarely do where you have done B-leach as well as you have inserted the balloon. I think to this August gathering now, everybody is tuned up. If you want to see how these procedures need to be done, you can watch my video, Surgical Management of PPH by Dr. Sheela on YouTube. You will get the demo of all these sutures on a uterus model. Okay, so I told you about the ligation, the uterine artery, uterovarian anastomosis, where you ligate that. Okay, you don't ligate in the infundibulopelvic ligament because that will hamper the blood supply to the ovary. Okay, so uterovarian vessels ligament to reduce the bleeding. This is internal iliac artery ligation. It is effective because it reduces the pulse pressure in the pelvic arterial circulation. Okay, almost by 77%. Okay, if unilateral, 85% bilateral. But that effect is not there and definitely the blood loss will come down. Tourniquet, I showed you. Whatever is available, we can just apply. You will have to have a sixth sense here. Sandwich procedure is like you have inserted the suture, then you put the balloon, you inflate only 100 ml, then you close the uterus, and again you inflate it from below. You have to take the precaution that you don't puncture it while closing the uterus. This is very important, aortic compression. Whatever you do, you have to learn, see to it that you control bleeding, that the bleeding is under control. So you stand on the right side only, use the left hand, go above the umbilicus, go on the left side, aorta is on the left side, and then palpate the femoral with the right hand. The pulsation should not be felt. The aorta is compressed against the vertebra. Okay? At least till you are making arrangements, everything, and if the patient is bleeding like a tap, you cannot allow her to bleed like that. You have to train your assistants for that. If you are doing a cesarean, take a wet mop, ask the assistant directly to compress. Be on the left side only, because on right side there is inferior vena cava. You are not supposed to compress that, otherwise the return will get affected. This is the Pailis clamp which Sir usage for the placenta accreta cases. You can go online and see his publications. He has used it, okay, to control the bleeding. And this is the interventional, like you know that she is a case of placenta accreta. She is going to bleed. We can put this balloon catheter placement before the surgery electively. And then once the uterus is opened and the baby is delivered, we can inflate it. Okay. So even in one of the centers in Bangalore, we find very good success rate and the patient requirement of the blood comes down. So these are the prerequisites. You have to have a facility. The patient has to be hemodynamically stable, and there has to be a hybrid theater where you can't take her to another floor, okay? And you will need a person who is expert. So dear friends, obstetric bleeding is fast, furious, and frightening. And there could be legal issues also because of lack of preparedness, inadequate action, that is the act of omission, lack of a poor communication and improper documentation. So it is very, very important that every time you document, and when you are referring the patient also, you should give a referral slip in such a way that what all you have done. Communicate with the person where you are referring. Okay. Competent health personnel should accompany the patient. So that empathy has to be there, and she should go to the nearest place. All the arrangements should be there. She should not waste time in casualty or anywhere. Directly, she should be attended. I always say that we have a code blue in hospital. We should have a code H for hemorrhage because it's very important so that everybody is sensitized and they know there is a woman who is bleeding and who needs attention. Thank you very much for your kind attention. Thank you.
Thank you very much, madam. Thank you very much. Very informative. Very interesting to know the newer techniques that are happening in the world of PPH. I mean, the surgical part of it. We discussed both medical and surgical. Thank you so much. Thanks all the doctors who took time and attended this. Thanks marketing sales team of Hitro. Thank you, madam. We can sign off. Wish you a very pleasant evening. Thank you once again.
Thank you. Thank you very much.